Here's a full article titled NAC Janus Kinase, JAK Inhibitors and the Heart, Cardiovascular Considerations in Anti-JAK Therapy. Introduction. Janus kinase inhibitors, JAK inhibitors, or JAKs, are a class of targeted synthetic disease-modifying anti-rheumatic drugs, TSMARDs, that have revolutionized the treatment of various autoimmune and inflammatory conditions, especially rheumatoid arthritis, RA, psoriatic arthritis, ankylosing spondylitis, and ulcerative colitis. Despite their proven efficacy, concerns have emerged regarding their cardiovascular safety profile. This article explores the cardiovascular implications of JAK inhibitors, summarizing current evidence and guidance for clinical use. Mechanism of action of JAK inhibitors. The JAK-STAT signal transducers and activators of transcription pathway is critical in cytokine signaling. JAK inhibitors block the intracellular activity of JAK1, JK2, JAK3, and TYK2 enzymes, which are associated with pro-inflammatory cytokines involved in the pathogenesis of autoimmune diseases. Approved JAK inhibitors include tofacitinib, JK13, JK2, baricitinib, JAK12, upadacitinib, selective JAK1, filgotinib, selective JAK1. Potential cardiovascular risks of JAK inhibitors. 1. Major adverse cardiovascular events may. One of the main safety concerns emerged from the oral surveillance trial. Tofacitinib versus TNF inhibitors in RA patients over 50 years with cardiovascular risk factors. Key findings. Increased incidence of MACE, CV death, non-fatal MI, non-fatal stroke in the tofacitinib arm, particularly evident in patients with pre-existing cardiovascular risk, e.g. older age, smoking, hypertension, diabetes. Meta-analyses suggest overall CV risk may not be increased in the general RA population using JAKs. Risk may be dose-dependent and population-specific. 2. Venous thromboembolism, VTE. Several JAK inhibitors, especially tofacitinib and baricitinib, have been linked to a higher incidence of deep vein thrombosis, DVT, pulmonary embolism, PE. The mechanism is not fully understood, but hypotheses include dysregulation of coagulation pathways, modulation of cytokines involved in thrombosis, e.g. IL-6. 3. Lipid profile changes. JAK inhibitors often cause a dose-dependent rise in LDL-C and HDL-C levels. No significant change in LDL-HDL ratio. The clinical significance remains unclear. Some argue these changes reflect reduced inflammation rather than atherogenic effects. Statins are commonly prescribed concomitantly if lipid changes persist. 4. Heart failure HF. There is no strong evidence that JAK inhibitors increase the risk of heart failure. However, caution is advised in patients with pre-existing reduced ejection fraction, history of decompensated HF, especially when combined with NSAIDs or corticosteroids. Protective or neutral effects. Interestingly, by reducing systemic inflammation, JAK inhibitors may offer indirect cardiovascular benefits. Inflammatory cytokines, IL-6, TNF-A, are involved in atherogenesis and plaque destabilization. Control of chronic inflammation reduces endothelial dysfunction and arterial stiffness. Some observational studies even show stable or improved CV outcomes with JAKs, particularly in patients with well-controlled disease activity. Regulatory warnings and guidelines. FDA US Black Box Warning 2021-2022. After the oral surveillance data, FDA issued a boxed warning on increased risk of MACE, cancer, VTE, and death. Applies to tofacitinib, baricitinib, and upadacitinib. Recommends use only after failure or intolerance to TNF inhibitors in patients with cardiovascular or malignancy risk. EULAR and ACAR recommendations. Risk stratification is crucial before initiating JAK inhibitors. Prefer TNF inhibitors in high-risk patients, aged 65, smokers, history of CVD or VTE. Shared decision-making is emphasized. Monitor lipid profile, blood pressure, and CV risk scores regularly. Risk mitigation strategies. Assess baseline CV risk using tools like SCORE2 or QRISK-3. Avoid JAK inhibitors in active malignancy, prior MI, stroke, or PE-DVT unless benefits outweigh risks. Treat modifiable risk factors, smoking cessation, statins for dyslipidemia, tight control of blood glucose and hypertension. Use lowest effective dose of JAK inhibitor. Reassess risk annually. Conclusion. JAK inhibitors are powerful tools in the management of autoimmune diseases. However, their use demands careful cardiovascular risk assessment, especially in older patients or those with pre-existing CV risk factors. While they do not uniformly increase CV risk in all populations, vigilance and individualized treatment planning are essential. Future long-term real-world data and head-to-head trials will further clarify their safety profile in comparison to other DMARDs. Certainly. Here's a detailed section on hyperlipidemia induced by JAK inhibitors and how to manage it in clinical practice. JAK inhibitors and hyperlipidemia, mechanisms, clinical impact, and management. Background and incidence. JAK inhibitors, especially tofacitinib, baricitinib, and upadacitinib, are consistently associated with increases in serum lipid levels, often observed within the first 4 to 8 weeks of therapy. Reported changes include LDL-C increased by 10 to 20%, HDL-C increased by 10 to 25%, total cholesterol increased by 15 to 25%. Triglycerides may also rise mildly in some patients. Interestingly, LDL-HDL ratio remains unchanged or may even improve, indicating a balanced lipid effect rather than a purely atherogenic one. Mechanism behind lipid changes. The lipid changes are thought to result from reduced systemic inflammation, not from a direct prolipidemic effect. IL-6 and TNF-α suppress lipoprotein production and increase clearance during active inflammation. When inflammation is controlled, e.g. via JAK inhibition, this suppressive effect is reversed and lipid levels normalize to baseline metabolic conditions. Hence, the rise in lipids may not necessarily increase CV risk unless the patient already has underlying dyslipidemia or cardiovascular disease. Clinical relevance. Despite lipid elevation, no consistent evidence shows increased atherosclerotic events solely due to JAK-induced hyperlipidemia. The oral surveillance trial suggested an increased risk of cardiovascular events, but the link between lipid changes and MACE was not direct. Risk was confounded by age, smoking, prior CV history. That said, lipid monitoring remains essential as part of CV risk evaluation. Guidance for lipid monitoring and management. 1. Baseline assessment before starting JAK. Obtain fasting lipid profile, total cholesterol, LDL-C, HDL-C, triglycerides. Assess CV risk using scoring tools. Score 2, Framingham, QRisk 3. Educate patients on potential changes and the need for monitoring. 2. Follow-up lipid testing. Repeat lipid profile 4 to 12 weeks after starting therapy. If significant elevation persists, e.g. LDL-C 130 mg per dL or triglycerides 200 mg per dL, consider lifestyle modification and/or pharmacologic intervention. 3. Statin use. Statins are the mainstay for managing JAK-induced hyperlipidemia. Tofacitinib and baricitinib have no major drug interaction with statins, although monitor liver enzymes, as both can have hepatic metabolism. Prefer moderate-intensity statins, e.g. atorvastatin 10 to 20 mg per day or rosuvastatin 5 to 10 mg per day, and titrate based on LDL targets. 4. Lifestyle measures. Encourage diet low in saturated fats and refined sugars, regular aerobic exercise, weight loss in overweight patients, smoking cessation. 5. Treatment thresholds. Follow general dyslipidemia guidelines, e.g. ESKEAS or AHHA. For low to moderate risk patients, LDL goal 130 mg per dL. For high risk, e.g. diabetic hypertensive, LDL goal 100 mg per dL. For very high risk, e.g. prior CV event, LDL goal 70 mg per L. If LDL goals are unmet despite statin therapy, consider adding ezetimibe, switching JAK inhibitor, e.g. from baricitinib to upadacitinib. If clinically appropriate, multidisciplinary consultation, e.g. with cardiology or lipidologist. Summary algorithm, JAK inhibitor and lipid management. Step action. 1. Baseline lipid profile. 2. Recheck at 4 to 12 weeks. 3. Assess CV risk, QRisk 3. 4. Lifestyle counseling. 5. Start statin if LDL-C above threshold. 6. Continue monitoring every 6 to 12 months. 7. Adjust therapy if needed, e.g. switch JAK or intensify statin. Final notes. Lipid elevations with JAK inhibitors do not necessarily translate into increased CV risk if properly managed. The benefit of inflammation control often outweighs the lipid elevation, especially in patients with active autoimmune disease. Clinicians should balance efficacy, patient preference, CV risk, and safety data in deciding whether to continue